So I'm going to talk about elderly patient in intensive care. So Ricky, please join in any conversations because we can't see you, we can hear it, and we do love you.
Yeah, cheers.
I'm going to start off with a question. So a couple of questions to the audience. Do we discriminate about admission to or treatment in the ICU on the basis of age? What do you think? Or do you think we do discriminate? Put the hand up or say aye. You think we do? You don't think we do? What do you think? You don't think we do? Okay. Ricky, what do you think?
I'm not sure I'd use the word discriminate, but I think it does alter our decision to admit people.
Okay, so filter maybe all of them. Okay. And the second question, should we discriminate on the basis of age?
Not the sole.
Okay, fine, we can end it there. And we'll just talk through some evidence. So I think we've probably got the answer. And the other thing I was going to talk about is how these decisions are made. So I'm going to give you an example. This is a real example. 90-year-old lady, cachectic, frail, self-isolating during COVID. So she presented this about this time last year. Hypertension, osteoporosis, previous hip replacement. She had an upper GI perforation and it was thought she needed laparotomy, and she was referred from ED, and the surgeons wanted us to help make that decision for them, the surgical decision. And the usual thing is, should we operate or would you give her an intensive care bed or support an intensive care bed if we did operate? She had a frailty score of 8, okay, but her EWS was 2. So this is in the past, and I'll reveal the decision later. What do you think we should? What would you do if all the consultants in the world were struck down by nerve centre virus and stopped working at 2 o'clock in the morning, and you're in charge? What would you do?
I think I would.
So you've got a no, yeah, no. So you wouldn't. Fine, okay, okay. So Ricky, you would. What do you think you would do?
I'd certainly be very strongly inclined towards no.
Well, that can't. This is a yes/no thing. You can't have a. You can't provide.
Fine. I would. Obviously, I would say no. Then I would say no.
Okay. Fine. So this bit we all know. What is ICU? What do we do? I thought it was worth just defining that. So what we do: organ support. We do trials of therapies that indicate indications. We also do palliative care, including family care, and that's an important part of our role. Into that sometimes comes organ donation. Another important thing is that we manage expectations in a way that the ED can't maybe because of time pressures, inexperience, etc. We do have a multidisciplinary approach, so we do involve, in addition to doctors, nurses, pharmacists, physios, dietitians, etc., etc. And this is Dale Gardner. No, it wasn't. It was Dan Harvey as a consultant in Nottingham. He describes ICU as 2/3 acute physiology, pathophysiology, and pharmacology, and 1/3 ethics. So I think that's probably about right. So about 1/3 of my job certainly is ethical considerations and decision making. Okay, and what does the Department of Health say? Well, ICU is about avoiding unnecessary suffering and premature death by treating reversible illnesses for an appropriate period of time. And every part of that phrase is important. So it's about avoiding suffering and death by treating reversible illnesses for an appropriate period of time, and improving clinical outcomes in suitably selected patient populations. Terrible English, but that's it. In other words, it introduced the concept of the capacity to benefit from intensive care. And so the guidance quite explicitly states that the condition should be reversible and there shouldn't be significant comorbidity. I hope it's not a too old person in there. We're supposed to improve survival overall, particularly by admitting patients at the right time in their illness. What don't we do? And this is really addressed to anybody who's outside ICU, is we don't admit all the sickest patients in the hospital, which is what many people think we do. We can't reverse terminal decline. We're good, but we're not that good. We don't prolong life when there's no hope of recovery, but we also don't leave the important decisions to others. So I think that counts in our favour. We do kind of hopefully make the important decisions. So how do we decide? Well, we all know the problems we've got. Our patients are getting older, they're getting sicker. At the same time, we're faced with increasing expectations from patients' families, colleagues in other specialties, MPs, politicians, single issue pressure groups, everybody has an interest in this. We do have more advanced and new treatments which can potentially improve outcome, but we're expensive and resources are limited. It's one of the unsaid things that we do to be honest, ration care to a certain degree. What's the other legal frameworks? Well, in 2005, the Mental Capacity Act was introduced, and that introduced some important rules that sort of underpin our practice. So one of those was this idea of best interest decisions. So we have to act in the best interests of the patient, but we also have to support individuals to make their own decisions, even when that decision is unwise. That's a general framework. So, and you see that in social care as well. Patients are, if they have mental capacity, allowed to make unwise decisions, and we can't do anything about that. And it also includes the idea of the course of protection and mental capacity advocates and legal power of attorney. So, what about a couple of on that sort of background, the law on which that was based? The sort of famous one was the Tony Bland case. He was one of the Hillsborough, the Liverpool footballers involved, football supporters in the Hillsborough disaster. And basically, he was left in a position of vegetative state, and his family challenged the decision to not offer him. So his family wanted withdrawal of feeding, and the doctors wouldn't allow it at first, and his family challenged that, and it eventually went through, but quite some considerable, not well, cost to the taxpayer, but also angst on all sorts of parties. And the other was another case of withdrawal in the case of a degenerative neurological disorder, and again, the court upheld the doctor's decision to withhold treatment. And the upshot of all of this, and the sort of the take-home message is that we're under no legal definition to offer treatment because the family or the patient wants it. So you don't have to do what the family wants to do. People haven't got that. You think about the Charlie Gard case of a couple of years ago, and another one that's just going through the courts at the moment. That's not generally in the public knowledge. They still will challenge it as they can, and lawyers will assist that process by large amounts of money. Conversely, patients do have autonomy, so they have a fundamental legal right to decide what happens to them, and we cannot force them to follow our advice. We can say, this is what we think you should do, but we can't force treatments on them. But we also can refuse patients treatment that we don't think is in their best interests. The other part of this sort of strain on legal and ethical matters is, on ethical matters. One of the pillars of medical ethics is this concept of beneficence and non-maleficence. First, do no harm, essentially. So we have to act in the patient's best interest and assess the pros and cons, potential benefits and risks of treatment. And we do have an obligation to discuss that in detail. This is kind of what we all know, kind of what we all do, hopefully, in our everyday practice. But what is the capacity to benefit? Well, when I was your age, and I'm a bit younger than you, I was a medical house officer, and my experience of intensive care was that when a patient was really, really, really sick, we would phone ITU, and they commonly dressed all in white from head to toe and would ride on a white horse around the hospital, and they would come and scoop the patient in white, or of course in white, and they would bring them back about a week later cured. So they were these sort of heroic figures that had magic powers that could do things to patients to improve patients' well-being, safety, health, etc., and reverse illnesses in a way that I, as a humble medical doctor, couldn't. And I kind of thought, oh, they know some things that I don't. Maybe I might have a go at that and see. And then I've ended up here. So that was one of my inspiring features in chasing intensive care as a career. And of course, when you find out this is what it's like on the right, you sort of in there, looking rather like George Clooney, of course, but surrounded by lots of machines. And it's kind of a bit more complicated, but in fact it isn't. It's basic principles with machines that go bleed. So what are the consequences of admitting patients to intensive care? Well, there are quite a lot. They depend on some things related to the disease process and some things related to ICU admission itself. So in terms of the disease process, the endocrine responses, the cardiovascular sympathetic nervous responses to acute illness, which include increased respiratory effort, work of breathing, sodium water retention, neurohormonal things, liver dysfunction, a list as long as you are. So there are consequences of any sort of severe disease, but those are compounded by the things that we do to people, be it that artificial ventilation, which is really quite bad for the cardiac output, and we see that in patients who, you go on to, you put them on a ventilator and everything crashes from the expecting it's going to be a perfect story. Other things we do harm, so drugs and sedatives relate to delirium, prolonged inability, pressure sores, infections, etc., etc. We give fluids, which can be harmful, whether we give enough, whether we give not enough, whether we put catheters and tubes and pipes and all sorts of things into people. They can all cause problems. So there's problems both of the various piece, but of course also of the monitoring. Tracheostomies go wrong. I've certainly seen patients as a direct result of tracheostomy. Feeding lines go wrong. Surgery goes wrong. The list again is as long as you are. And the other things we're kind of increasingly appreciating are the problems related to the physical environment. We know here because it's a small, cramped, dirty sort of unit, but sleep deprivation is a real problem. Cross-infection, psychological problems. So we do harm people, as well as the harm from their illness, we do harm people by the consequences of our treatment. Okay, come back. So what things really determine whether the outcome from ICU? Well, there's a variety of kind of obvious things. One is the physiological. Probably this is about the most important. Cardiorespiratory reserve in conjunction with their previous functional state, so frailty essentially. But the other things are how reversible the disease is, and that's also a fundamental thing. So the disease is not reversible in the current context. In other words, when we see this all the time with hematology or cancer patients, they say, oh, this disease has a 80% 5-year survival rate, and we say not in a 90-year-old who's in a nursing home. So it's in the current context, or not in somebody who's already got respiratory failure on top of a course of chemotherapy. So it's in the current context. It also depends on whether it's surgical or medical. Generally speaking, on average, surgical ICU admissions have a better outcome than medical. Partly because many of them are elective, but there you go. It's better if it's elective surgery. Things like multiple organ failure, ARDS, some hematological malignancies are generally bad news. Patients with immune dysfunction, inability, neurological dysfunction are also prognostic factors. So, and some specific diseases, alcoholic hepatitis, for example, has a bad prognosis as a consequence of the disease, never mind similarly severe pancreatitis. But we have to take those into consideration in conjunction with other factors such as comorbidities, severity of the illness, single organ, multi-organ failure, surface scores, what have you. Also the timing of admission, so generally if we can admit and
do the X-ray, so I run 2, just done it.
yeah. Can you shut the door and not let anybody else in when you come out? Apart from you can't come back. So only urgent interventions. And the other important thing, I presume you're aware of this, and it's quite well shown with the data, is that if somebody's condition doesn't improve over the first 48 hours, that's generally a bad prognostic sign. So the patients that are going to do well often improve in the first 24, 48 hours. In other words, in response to simple measures such as it might be draining of an abscess, it's source control of infection, it might be starting cardiovascular respiratory or even renal support. The ones that do badly are those when you do everything and they still don't improve. It's not an absolute, it's one of those sort of answers. And that then brings us to the concept of admission for a trial therapy. Because you'll always be surprised throughout your career. The other sort of elephant in the room is that patients don't survive so much if we limit treatment. So we have to kind of be about that. But age is in there. We often use the Rockwood Clinical Frailty Scale. Now, this can only, I mean, you all sort of know the numbers, above 5 is bad and less than 2 is sort of all right. And apart from looking at that, from very fit, managing well, living with mild frailty, does anybody else know the limitations of this scale or what it was developed for? Or why you should only pay a certain amount of attention to it?
It's to do with their age group.
Yeah.
It's not.
Yeah.
Without.
Yeah. So it was developed as part of something called the Comprehensive Geriatric Assessment, the CGA, by a chap in Canada called Rockwood, funny enough. And he developed it for patients over the age of 65. So it wasn't necessary for ICU or for hospital admission, it was for an assessment of somebody's overall status, really, in terms of whatever social care, medical care, what have you. But it was only aged over 65. And the other important thing is it should be assessed on the baseline capabilities of the patient, not their current state. So many patients are rendered a lot sicker and a lot less able because of the current illness they've got. People who do this score downstairs don't know that. But whenever you get a score of 5, you just need to kind of look back and say, well, what were they like 2 months ago? And what's their normal status? Is it a disease? And put that into context. Okay, so what does aging do to you? Aging is kind of bad, really. The rule of thumb is everything sort of every function decreases by about 1% from the age of 30. The cardiovascular bit, respiratory, any sort of organ function, brain function, including we get reduced cardiovascular capacity because of reduced reserve, specific problems with the heart, reduced respiratory function, kidney, all of these things. Everything just gets a bit worse. So at the age of 80, you've got 50% of the capacity used. And that's even in the absence of any other illnesses whatsoever. But it's made worse if you've got chronic diseases, if you've got comorbidities, people end up on lots of drugs, you get drug interactions. And people get deconditioned and more frail or mobile. We've seen that particularly over the pandemic. I'm sure you've seen it with elderly relatives, and all other people. So, just as a slight aside, and as an analogy, these are various world athletic records. I've got a series of about 5 or 6 slides by age. So these are the world records achieved at whatever age. So this is 100 meters. Can you see that over there? Can you see this? Yeah. So the world record is just under, it's 9.78 or something. It's Usain Bolt. He set that when he was 26. But you can see the time, so at the age of 75, the world record is still about 15 seconds for a 75-year-old. But after about 80, 85, it goes up. It goes up an awful lot when you get to 90, 95. That's partly because there aren't many 100-year-olds doing, the pool is smaller, but you can see that's an effect of aging per se. And these are the athletes, these are the people without, you know, those comorbidities, drug interactions. That's 100 meters. This is the mile records, and again you can see the records are men are faster than at all age groups, but that the curve starts going up after the age of about 60, 65, 70, it gets steeper and steeper. If you look at some of the pole vault, which is a combination of aerobic exercise and agility and flexibility and strength, then that's a more gradual decline. So maybe the effects of aerobic exercise are sort of weighted towards the latter years. And the same sort of thing for Javelin. Now, I've asked you those top three. That Jan Zalesny, who's the world record, but his individual performance at the age of 35 decreased compared when he was 30, and it decreased when he was 40. So even the top athletes in the world declined with age, and that's all he did. That's his job, was to get a pole and jump over a pole. So it's you know, it's not like he was working nights or anything. So again, performance decreases with age. Look at the marathon; it's the same sort of thing. The asterisk at the bottom for 70, 75, and 80. Again, that was the same chap, somebody called Ed Whitnell, thank you for you. I've done at 85. So his times increased quite markedly. And if you do the reciprocal of the marathon, that's a sort of analogy for functional performance declining with age. The decline, I think, gets steeper from the age of about 70, 75. And you'll see this in your own family and maybe in patients as well. How your parents are relatively, I don't know how old your parents are, but they're relatively young people at the age of 60. But by the age of 70, they are slowing down, and by 75 and 80, they're a lot slower. So that, you know, again, these are athletes, and it gets compounded by illness and comorbidities and things. This is a sort of conceptual representation of what happens with age, and it's a sort of more a parallel of the sort of pole vault decline, so 1 to 2% per year. The top red line is your health on a base scale, normal scale of 100, 0 to 100, or the health capacity. And on the top left in the red, that's a young person at the age of, say, 36, having a minor illness that they make a full recovery from, but they otherwise continues to decline. The grey one below is a more significant illness. Might be an ICU admission, it might be major surgery, whatever. They will make a recovery. That recovery is more prolonged, but they may forever have a lower functional capacity than they would have had they not had that illness. Particularly if it's a more severe illness. If the same thing happens to them at the age of 50, that's the sort of turquoisey line there, they will recover, but never to full capacity, and even less than they would have if they had the same illness at 30. So your ability to recover for cardiovascular everything else function is also a function of age. And if you get very severe illness, thinking with complications, that's the orange line there, it's even worse. You might die. And similarly, if you get a very severe illness at an elderly age, then that can reduce it. Either severe impairment capacity or death. And we all kind of know that, but it's worth thinking about. Now, some data from here. So I looked at the ICU admissions between 2003 and 2015. The blue at the top is the total admissions, and then the various other ones are stratified by age. You can see we take about 50% more admissions than we used to. It's not gone up much more than 15 previous, so I left it at that. I think what the interesting thing is the bottom three are the proportions of patients in the elder that we admit. Those have gone up quite significantly. So in terms of between age 66 and 75, we admit about double the number of patients. And in terms of the over 85s, it's gone up by about fourfold. So we're admitting a lot of more elderly patients than we were when I started as a consultant. But if you look at the mortality of those patients, the mortality again, this is slightly difficult, you can't see that, but the bottom two lines are the mortality by age for the last 2 3-year cohorts, so it's 2012 and 2015. So in fact, for the most elderly patients, we're admitting more of them, but their mortality has gone down. So the ones we are admitting are doing better than the ones that we admitted in 2023. So I think it's quite interesting, really. And it's the same sort of pattern if you look at hospital mortality by age. So, okay, what have other people said? Well, there's quite a lot of data suggesting that, well, showing that age per se is associated with bad outcome, particularly over the age of 80. Most of the studies we've done in those over 80. So this particular study, which has got a big study, suggested that there's a medical ICU patient cohort. The survival was about 60% after 2 months, but only 33% after 2 years. And the factors that determined that were whether somebody had a terminal disease, whether they needed ventilation, whether they were unconscious. Age over 85 was a bad thing as well, and whether they had shock. And survival after discharge from hospital related again to underlying terminal disease or poor functional state. So age was in there, but other things were important. This is another big study, European study. Again, 23,000 patients, which 3,000 over 80, and those group 0, 1, 2, and 3 sort of, they roughly correlate with group 0, 1, 2, and 3 roughly correlate to level 1, 2, and 3 or level 0 patients. It's a number of organ supports, and you can see with age along the x-axis at the bottom, mortality, overall mortality goes up with age in all groups, but particularly in those needing multi-organ support, so level 3 patients. So, 65% mortality. So it's related to severity of illness, level of support required, as well as age. Here's another similar big study, again, showing, well, if you just look at the graph there without reading anything else, that mortality does go up with age. Having said that, the mean admission is increasing, and that we've seen in our data as well. We are admitting more elderly patients. Of those, the higher proportion female. I suspect that's because they comprise a high proportion of the over 80 population to some degree. Of those we do admit, most have few or no comorbidities. We often ration treatment. However, there was no difference in length of stay in this particular study. Although higher hospital mortality, other factors were more important than that as well. So whether some functional status patient condition. There's another study, again, mostly study, and mean age 85, 30% stayed over a week, and almost 20% had limitations of treatment on admission. But if you look at the top one here, the number of patients who died after 7 days, their total hospital length of stay was 23 days. That's quite a lot. They still died, but they were in hospital over 23 days. They were in ICU for about 30 days. And if you look at the range from the top, some patients who died after 7 days were in hospital for over 2 years. So about 6 days, 6 to 29 days. If you look at then the overall mortality in ICU is 22% or 35%. And another study here of ICU patients, quite a significant mortality, and it continued to go up after they've left hospital. That happens with every age group. It's more marked, I think, in the elderly, not because of age per se, but because of functional capabilities, physiological reserve, all these things we just discussed. And in this particular study, only a quarter made a physical recovery a year. What I come around to is other things more important than just survival. I'm going to skip these now, but the rest of the data says that this actually thing. Yeah, so what's important? There's some interesting things. So this was elderly patients who had terminal illness. And so they were asked what's important to both the patients and family members. They wanted to be involved in the decisions, to be able to trust the doctors, what they said, and that was the most important thing. They also wanted not to be kept alive if recovery was futile or treatment was futile. I didn't want to be a burden, or I wanted to preserve their dignity. And also, so this is what's important to patients. It's not necessarily survival. It's the chance to say goodbye, keep the dignity, and have confidence in that sort of decisions. Is this the, yeah, this is, yeah, okay. So another study of elderly patients who again was considered high risk. So they had terminal heart failure, kidney failure for this one. Most of these have considered end of life, and about half of them had advanced directive. And very few of those prefer lifelong care. Interestingly, there are other data which suggest that patients who have medical illnesses which are restrictive of life expectancy, so things like terminal heart failure or kidney failure or dialysis, they have really quite unrealistic expectations of their life expectancy compared with patients with cancer. So patients with cancer, well, it's often discussed very explicitly in the clinic, and they know they've got some risk of patients with maybe stable chronic heart failure. That's just them, and they don't think that actually is, they could deteriorate at any given time. So they don't consider that as a life ending process. And this is another quite interesting French study in patients who are either they've all been in hospital, most of them were at home, but several were in nursing homes. And they were presented with this scenario, so a detailed video scenario. So this is what renal replacement therapy involves. This is what ventilation involves, non-ventilation, etc. And many of them, having seen this, refused to have those, prospectively declined to have those sort of treatments. And the reasons were they considered their independence, they thought they were too old and wanted to be and thought that the time had come, sort of thing. And I think we often don't necessarily answer those questions of our patients. And quality of life was important to them. Okay, I'm going to skip these for time. What we also should remember, so we do the question asked, does age affect our decision making? Should it affect our decision making? Well, it's compounded. So age per se, many of the studies that are involved are limited because they just look at age as an option and don't consider the other, maybe undocumented or maybe unseen things that go on. One is doctors' sort of bias or heuristic decision making. The fact that we may often treatment but with limitations, withholding certain treatments, and you will have seen that here quite frequently, rightly or wrongly. You may disagree, and if you do disagree, you should always feel that you can answer questions as to why that decision has been made. In general, elderly patients in larger cohorts have high mortality, but if you take selected patients with few comorbidities, they actually do okay. And that's shown, I think, by our sort of unfiltered audit data. The other problem, there is significant variation in decision making between doctors. This was a study we were involved in. It was coordinated from Coventry, actually, and it confirmed that our decisions consortium, so largely based on uncertainty. There's something called heuristics. Do you know what heuristics means? No, this is a great paper. It's got the word heuristics and gestalt, both of which are kind of not simple words. So heuristics is the idea that you that in complex decision making, that decision is simplified by the person making the decision, and it's kind of accurate for ICU decision. The decision itself is simplified because of the experience of the clinicians, in this case involved. In other words, you can filter out all the noise and base a decision on your practical experience of this particular scenario. Gestalt is related to the sum of the parts being greater, the whole being greater than the sum of the parts. It also showed that we often fail to ask the patients or the families' wishes. We don't sometimes have time to do that in the emergency situation, but we certainly can do at the event. But we were rarely talked about the burdens of intensive care to the patient at the time. So, we talked about doing it at home. Prognostication is an imperfect science. Patients and their relatives want us to give a degree of certainty that that is never there. And we have to discover think about what our best interests are. Consider the burden of treatments, who are the relevant parties, patients, their loved ones, family, etc. And what are the important outcomes to the patient. So it might not be life or death, it's quality of life. It might be, I want to survive until my son's marriage next year. That's more important. Even if I have to be wheeled there in a wheelchair attached to a dialysis machine, I want to get that. And that's a valid reason for treatment. We also have this, I talked very briefly about resources and allocating resources. We do have to do that, I'm afraid. But that's okay, that's a moral and ethical thing. It's our duty to distribute resources appropriately. So distributive justice is what that means. It means, if you're offering treatment to that one person against the other person, it's our duty to society to maximise the benefit for the whole rather than that individual. Okay. So back to our 90-year-old lady, who all of you said no, I think. Yeah. Well, I said yes. So I went down there and said, met with her and examined her, and I said, I had a chat with her. I said I would have a bit of post-operative care. However, a family came along and they said, oh no, she's more frail than suggested, so they suggested they declined surgery. And then what happened? She goes onto the ward and she survived, discharged after 5 days, and she survived well. So it just shows you don't quite know. My decision was based on the fact that I didn't think Francis was quite as bad as he was presented, although she was kicked out, she hadn't been out for years. But an upper GI perforation is survivable. And so it wasn't, a fecal peritonitis or a severe pneumonia, so it is as a worse prognosis. But that is a clean operation that can be done in half an hour. But I thought, well, she's got a chance, and we probably ought to offer the chance. So, if she had felt multi-organ failure on day 3, we would have had a different conversation. But it's not. There's a trial therapy. I got it right because she got better, but I also got it wrong because she got better than me. I've been admitted. So what was it? Anyway. So that's it. Thank you, Ricky. Are you still listening?
Yep, still listening. Yep.
Finished.
It was good. I enjoyed that. I do find it really interesting. Like the ethics stuff is fascinating, and it is one of those things that it's not really talked about in the curriculum. Everyone's focused on, ventilators and inotropes and whatnot, and actually ethics is so much more of the job as the consultant, really.
It is. I mean, I guess part of the question is, it doesn't lend itself to MCQs and true false answers, or even to short single best answers, because largely there isn't a a single correct answer in any given situation, I don't think. But it's important for people to think about at a relatively young age in their career. If you consider my student career, you end up doing a lot of this sort of stuff, like, you know, head scratching and talking to families as much and trying to act in people's best interest. I do it, it's very much like general practice with machines, actually. Lots of hand holding, that sort of stuff. Bit of science. Good, thank you.
Thank you.
Anyone else got any questions in the room?
You mentioned about people make improvements in 24, 48 hours.
Yeah.
Is there anything to do with the degree of improvement? So if they improve a little bit, they're slightly more likely to, like if they improve a lot, significantly. Is that anything, or is it just some improvement versus more?
I don't think it's been looked at in that amount of detail. In other words, you know, an X amount of blood pressure change. You know, all these things are so open to manipulation. You know, the stuff about you hear it every day when the patient's got it. I've managed to get the NORAD down. That's the nurse's thing. I've got the NORAD down. That's their goal for every shift. So I've got the NORAD down, and if they can go home happy if they've done that. The fact that it's A, because the patient's had an operation, B, because we've turned the sedation on, C, because they were hypovolemic before and we've given them 3 litres of fluid, or a number of other sort of factors, is irrelevant. So, you know, that's part of what's difficult to say an absolute change in blood pressure is. It's also compounded by the fact if somebody is borderline and are not improving in 48 hours, that's often the time you've got to make the shall we filter them decision, or shall we continue, or should we offer, you know, increase X, Y, and Z. So, you know, sometimes if there hasn't been, or if they've been admitted for an assessment of response, they haven't responded, you actually kind of make that decision for them. That can compound those sort of but so, and you know, it's often if somebody's not deterioration or begun to turn down, or you know, the lactate's come down a bit, even though it's still on vasopressors, it's not one single thing. It's a sort of gut feeling that things haven't got worse or they're not close to death's door. So the short answer is there's not a single quantifiable criteria by X amount of improvement. It's often just an amalgamation of several little things. Good, I'll leave it there then. Thank you very much.
Thank you.